Hello, everybody, and welcome to our question lab this evening. We're happy to have you here. As you are aware, tonight's question lab is going to be focused on step 2, and we're happy to have all of you in attendance. Leading tonight's dissection is going to be Kasha Bornstein. He's going to introduce himself now.
All right. Hello and good evening, everybody, or perhaps good day where you are. I hope y'all are doing well. I'm a fourth-year medical student here in Miami, Florida, finishing up. Prior to medical school, I graduated from the Tulane Pharmacology Master's Program. And before that, I worked in EMS as a paramedic and paramedic educator for several years. I've been working as a study coach and tutor with the Coach RX project for just about a year now, working with students one-on-one, mainly regarding preparation for Step 1 and Step 2, but also in helping students build content knowledge for school exams and their shelves. I absolutely love working with y'all to help build confidence and knowledge to tackle these big exams, and we're gonna get into it working on some Step 2 content tonight.
Excellent, and we're happy to have Kasha here. We also have some panelists with us. We have Kate, who you'll meet later. She'll be conducting our raffle at the end, so make sure you stick around because one of you will win a very valuable prize. We also have in attendance one of our most experienced RX coaches, Abraham Titus. Dr. Titus, you want to introduce yourself?
Thank you, Shan. My name is Abraham Titus. I'm a current resident doing my internal medicine residency at Marshall University. I've been with RX Coach for over a year and have helped hundreds of students kind of work their way through Step 1 as well as Step 2 and help them achieve their goal. So I hope to see you guys and one day be able to tutor one of you guys. Thank you.
Excellent. Thank you, Abraham. And yes, keep in mind that we do tutoring for Step 1 and Step 2. And a lot of students always ask us, if I buy the 20-session package, if I have sessions left over, can I save them for Step 2? And the answer is absolutely you can. So if you, for some reason, don't use all your sessions while you're studying for Step 1, you're welcome to save those and use them for Step 2. My name is Sean. I've been with RX Coach for, I guess, almost exactly 2 years now, working with students and our coaches to help all of you maximize your potential and really make your studying more efficient. So we'll talk more about RX Coach a little bit later this evening. The first step of our process as we get into the first question is to cover up the answer choices. And we do that because we don't want the answer choices to guide or dictate your thought process. We don't want you to see an answer choice that you might be unfamiliar with and that might cause you to panic as you're reading the question. We certainly don't want that. So we've gone ahead and removed those answer choices for you. And once we cover up those answer choices, we will begin by reading the lead-in. And the lead-in is the last sentence or the question itself. So here we go. Which of the following tests is most appropriate to make the diagnosis? Which of the following tests is most appropriate to make the diagnosis? After we read the lead-in, we'd like to ask our students how many steps they believe the question will require. An example of a one-step question could be, what is the diagnosis? An example of a two-step question could be where they ask you, what is the treatment for a diagnosis? And an example of a three-step question could be where they ask you, what is the mechanism of action for a treatment for a diagnosis? So with that in mind, please let us know in the question box how many steps you believe this question will require. And we read the lead-in first because we want you to know what the test writer is asking before you read the question. That allows you to pick up on all of the relevant clues right away. Knowing how many steps it requires allows you to keep an organized thought process so that you answer the correct question and don't miss any steps on test day. So with that, let's go ahead and read the vignette. A 42-year-old man visits his primary care physician for a blood pressure check. Over the past year, the patient has had consistently severe elevations in blood pressure despite initiation of treatment with lisinopril, amlodipine, and metoprolol. Today, his temperature is 37.1 degrees Celsius or 98.8 Fahrenheit. Pulse is 64 per minute, and respiratory rate is 12 per minute. And blood pressure is 145 over 102. His exam is normal, and serum studies show sodium of 140, potassium of 3.1, chloride of 100, bicarb of 29, and creatinine of 1. Plasma aldosterone concentration is 22, and plasma aldosterone to renin ratio is 38. Which of the following tests is most appropriate to make the diagnosis? So we'll give all of you a few seconds here to think about the clues and which clues are important. And with that, I will hand it off to Kasha.
All right, so thanks, Sean. So this is a great question, and I think is a very, very typical kind of step 2 question. And we'll talk about some of the reasons why there's some important concepts to consider here in how we read this question. So what we can do is go ahead and show you what pertinent points we think are important, the pertinent clues in the vignette and the lead-in. And we'll start, as always, by asking, which of the following tests is, asking what kind of question this is, which of the following tests is most appropriate to make the diagnosis? So I think of that as a classic 2-step problem, requiring us to first figure out the disease and then the appropriate next step in diagnostic evaluation. So with that in mind, let's take a look at the beginning of the vignette. And I like to start off with the demographics. This is really critical. It can get you started off thinking about what conditions are more consistent with the demographic at hand. Diseases that 5-year-olds get are different from those that 15-year-olds get, and those are also different from what 50-year-olds get. So some other things that are important that we highlighted in this slide are the practice location, which sometimes, and particularly in step 2 style questions, which focus on management, can give you a clue as to whether this is asking about outpatient management of a chronic condition versus the acute presentation of a potentially life-threatening disease state. Then they're telling us that this patient has had elevated hypertension in the setting of what appears to be maximal management with multiple types of antihypertensives, right? We've got lisinopril, amlodipine, and metoprolol. And that might be concerning. It may be something that I don't want to get too deep into it without giving the answer here away, but definitely this is relevant. So then we see that there's some labs, of which the most relevant pieces here, I think, are the potassium, the bicarb, and those plasma aldosterone and plasma aldosterone to renin ratios. So coming back to this 2-step question lead-in, let's remind ourselves that we need to figure out what the diagnosis is and then the next step in diagnosis. So let's now go ahead and take a look at these answer choices. And when we look at these answer choices, what we're going to do is start at the bottom, as Sean has brought to our attention, and work our way to the top. Many of you who have been along for the Step 1 QLabs will recognize this. It's a really critical strategy in making sure that you consider every answer choice and don't miss anything by stopping at an answer that looks familiar rather than selecting the truly correct answer. So this way you prevent yourself from falling into a cognitive trap or biasing yourself. So let's go ahead and do that right now, starting at the bottom with answer choice E, which is MR, or magnetic resonance angiogram of the renal arteries. We've got answer choice D, which is a Doppler sonogram, or an ultrasound of the renal arteries. C, captopril renal scan. B, CT of the abdomen. Or A, bilateral renal vein renin and aldosterone sampling. So go ahead, we'll give everyone a chance to look and think about which is the best next step in diagnosis, and Sean is going to open up the poll. So please select the answer you think is correct, and we'll talk about it in a moment.
Excellent. Thank you, Kasha. So the poll is open. We'll give all of you a few seconds here to respond. Many of you were asking us, or some of you were asking us about Step 2 CS and the recent announcement made regarding the exam. I went ahead and posted a link to the announcement about Step 2 CS in the chat box, so feel free to take a look at your convenience. All right, I see about a quarter of you have voted. We'll give all of you a few more seconds here until 2/3 of you have submitted your responses, then we'll get started. I also noticed that some of you jumped straight to the answer or the diagnosis. Remember, this is not a competition with your peers to see who gets the answer first. The only person you're competing with is yourself, and we encourage you to follow all of the steps to make sure that you don't make any careless mistakes and lose valuable points, okay? So we'll give all of you a few more seconds here, and let's see what you selected. It looks like 32% of you selected B, CT of the abdomen, and in second place with 27% was answer choice D, Doppler sonogram of the renal artery. So let's take a look and see what the correct answer is. The correct answer is B, CT of the abdomen. So well done to you who got it correct. If you didn't, don't worry. Kasha is going to explain it to you now. Kasha.
All right, thank you, Sean. So let's go through this question again and pick out the pertinent information that we need to identify why answer choice B was the correct answer in this two-step question. So this can be a really tough question because it's asking you to determine a diagnosis of exclusion here, which some of our guests in the chat identified, which is treatment-resistant hypertension, or perhaps more specifically, secondary hypertension. So maybe you can share in the chat some of the causes of secondary hypertension, and we can get into this a little bit more. I'd love to see you share what your thoughts are on causes of secondary hypertension. Well, you can think about it, and we'll talk about this. So secondary hypertension presenting with hypokalemia, metabolic alkalosis, and elevated plasma aldosterone with low renin, as we see in this vignette, is suggestive of primary hyperaldosteronism, which generally speaking can be due to two causes: bilateral adrenal hyperplasia or an aldosterone secreting adenoma in one of the adrenal glands. Broadly speaking, this question is asking you to differentiate between these two separate causes of hyperaldosteronism, this bilateral renal artery stenosis, versus primary hyperaldo from an aldosteronoma, right? So in this patient, the aldosterone level is high, and a high renin level would suggest renal artery stenosis, or very rarely a renin-secreting tumor. A low renin level, as here, suggests primary hyperaldo. Now, the high aldosterone levels causing potassium wasting in the urine lead to hypokalemia, excretion of excess protons in the urine leading to metabolic alkalosis, and volume expansion leading to hypertension. That really gives us some of the important clues here. Now, a CT scan, or answer choice B, is the best test to identify the tumor, which may then be removed surgically in an attempt to cure the hypertension. I usually like to go through the other answer choices from the bottom up, same as reading them from when we first look at them. But I want to drive home an important point, so please follow along with me here. Some of you may be asking, why not answer choice A or answer choice D? Now, answer choice A, which is bilateral renal vein renin and aldosterone sampling, would likely provide a definitive diagnosis. And there's a useful conceptual test-taking tool that we can use, and that, in fact, Sean taught me early last year before I myself took step 2. And that is, when choosing between the best next step in diagnosis or management, think about this: simple before complicated and cheap before expensive, right? And so that's that kind of last step or last step when dissecting a question that's a little distinct for step 2 versus step 1. I'm going to say it again: simple before complicated and cheap before expensive. A CT is cheap and non-invasive. And while bilateral renal vein renin and aldosterone sampling would be definitive, it's much more invasive and performed to find the site of an aldosterone secreting tumor when other simpler tests have failed, or when surgery is planned to confirm the site of the tumor. It would not be the next test ordered here. All right. So with that in mind, we can now consider the other answer choices. Answer choice E, which would be the MR angiogram of renal arteries, is an expensive but non-invasive test to evaluate renal artery stenosis, a common cause of high renin, high aldo hypertension. So this is wrong for a couple of reasons here. A low renin here makes this unlikely. It's neither the first step in workup for the disease it's used to diagnose, nor the correct test for the condition at hand. Moving along to answer choice D, which is Doppler sonogram of the renal arteries. Now, that would be a great option in the initial workup for evaluating renal artery stenosis. Again, a common cause of high renin, high aldo hypertension, but the low renin that we have here for this patient makes this unlikely. So we can go to answer choice C now, which would be a relatively inexpensive and non-invasive test, but again, not for this condition. And again, not even the first step in the workup for the disease it's used to diagnose. Captopril renal scans are performed to evaluate renal artery stenosis, Again, common cause of high renin, high aldo hypertension. All right, nice work, everyone. Let's move on to question 2.
Excellent. Thank you very much, Kasha. Great job to those of you who got it right. This is a challenging question. Once again, if this is your first time attending one of our question labs, please let us know in the question box. We'd love to hear from you. And with that, let's go ahead and move on to our second question of the evening. Our answer choices are covered up, and we will begin with the lead-in. Which of the following is the most appropriate next step in management? So once again, we will give all of you a few seconds here to respond and let us know how many steps you believe this question will require. And then we will begin reading the vignette. All right, well, let's go ahead and read the vignette. A 35-year-old woman comes to the physician because of bone pain. She claims that the bone pain is generalized throughout different parts of her body and that she has had a feeling of aching bones in her arms and legs for the past week. She has also noticed a generalized weakness for the past few months. Her temperature is 37.4 Celsius or 99.4 Fahrenheit. Pulse is 110, respirations are 22, and blood pressure is 105/70. Physical examination shows generalized pallor. Blood is drawn, and an examination of the peripheral blood smear shows a large number of white blood cells with an increased cytoplasm to nucleus ratio consistent with blast cells. Upon further inspection, the cells have rod-like material that is myeloperoxidase positive. Follow-up bone marrow biopsy confirms greater than 20% blast cells in the marrow. Laboratory results are shown. She is admitted for treatment and management of her condition. White blood cell count 110,000. Hemoglobin 7. Platelet count 50 times 10 to the 9th. Sodium 135. Potassium 5.9. Chloride 100. Bicarb 26. Creatinine 1.6. Calcium 8.1. Phosphorus 5.7. LDH of 300. And uric acid of 9. Which of the following is the most appropriate next step in management? And with that, I'll hand it back off to Kasha.
All right, thank you, Sean. So let's start again by thinking about what kind of question this is and how many steps this question should be to answer it, because we want to maintain focus on what aspects of the vignette we need to pay most attention to. So this question is asking us, which of the following is the most appropriate next step in management? And almost certainly a two-step question, basically rendered as, what is the diagnosis and how do we manage this disease? So with that in mind, let's start from the top. We highlighted here some of the pertinent words and data that we felt are most important to solving this question. First, as always, age and sex demographics are really important. And then we're given the practice location, which is the emergency department here, which may be a clue as to the acuity of the patient. We can see the chief concern is generalized bone pain and weakness, and some concerning vital signs and physical exam findings. Particularly, I think, the pulse, the respirations, and this pallor, right? She's tachycardic to 110, she's tachypnic to 22, and she's pallid. So this question then gives us some diagnostic clues as to the nature of the disease at play. They tell us about blast cells and myeloperoxidase positive rod-like material seen on the peripheral smear. And finally, we're given to consider these lab findings with anemia, thrombocytopenia, hyperkalemia, elevated creatinine, hypocalcemia, and elevated phos, LDH, and uric acid. Basically, I like to think all the intracellular ions and products spilling out into the bloodstream. So let's come back now to consider this two-step question lead-in and remind ourselves that we need to figure out first what the diagnosis is and then the next step in management. Okay, so with that in mind, we can take a look at the answer choices starting from the bottom and reading up. So is the next best step in management E, vancomycin and cefepime, D, intravenous fluids and rasburicase, C, to begin induction chemotherapy, B, to administer phosphate binders, or A, to administer a bicarbonate drip. All right, so we'll give everyone a few seconds again to gather your thoughts, and I'll hand it back on over to Sean.
Excellent. Thank you, Kasha. I'm going to go ahead and open up the poll and give all of you a few moments here to select your answer choices. So please take a moment to select what you believe is the correct answer. I see some first-time attendees. I want to welcome all of you. We do these question labs every Tuesday at 8 p.m. Eastern. Today is step 2. However, next week will be step 1 once again, and we'll be focusing on general pathology. I see the responses coming in. We'll give all of you a few more seconds here. All right. And let's go ahead and see what all of you selected. And it looks like we have a clear favorite here with 54% of you selecting answer choice D. So let's go ahead and see what the correct answer is. And the correct answer is, in fact, answer choice D. So great job to all of you who got it correct. But let's make sure you got it right for the right reasons. So Kasha is going to explain it to us now.
All right, great work, everybody. That was a nice showing on this question. For those of you who got it right, as Sean said, let's make sure we got it right for the right reasons. And for everybody else, we'll also work on making sure we get this question right for the next time that we see this concept come up. So let's go ahead and break down what was at play in this question. This question vignette involves a 35-year-old patient, a woman, presenting with bone pain and generalized weakness with findings highly concerning for acute myeloid leukemia, particularly given the presence of our rods in the cells seen on her peripheral smear. This patient's laboratory findings are suggestive of tumor lysis syndrome, as reflected by the elevated serum levels of potassium, phosphate, uric acid, and LDH, the decreased serum calcium, and an acute kidney injury with an elevated creatinine. I like to think when I see elevated potassium and phosphate and uric acid and LDH, all of these are suggesting to me that all the intracellular components are spilling out into the bloodstream, and that phosphate binds calcium, which explains why that's low. And all of those, I like to think, bad humors of cellular lysis are toxic to the renal tubules, which is part of why you get that acute renal injury. So tumor lysis syndrome is an oncologic emergency caused by lysis of tumor cells, which release those intracellular products. Elevated potassium levels can lead to arrhythmias. The elevated phosphate levels lead to hypocalcemia. And nuclear material can precipitate as uric acid crystals in the kidneys, and you can develop crystal nephropathy, or really an acute renal failure secondary to that uric acid layering down into the kidneys. Now, prevention and treatment of tumor lysis syndrome requires answer choice D here, which would be intravenous fluids and rasburicase. Aggressive fluid hydration is used to induce high urine output, while rasburicase is preferred for crystal nephropathy prophylaxis in high-risk patients, such as this patient, because it increases renal uric acid clearance. Administration of allopurinol has also been shown to decrease the risk of uric acid crystal formation and the subsequent renal dysfunction you would see. And so that's a good answer to consider if you see this concept come up again, and allopurinol is one of the answer choices. Allopurinol, however, should be given as prophylaxis in intermediate to high-risk patients, while rasburicase is typically used more for treatment once it's already started to occur. However, the cornerstone for management of tumor lysis syndrome is the aggressive IV fluid hydration. So also important to know is that this is really, when you see these patients or you're considering that somebody is at high risk for tumor lysis syndrome, such as this patient who has this acute myeloid leukemia, but also other types of cancer in which there's a really significant rate of high turnover, aggressive cancers that are being treated with induction chemotherapy. IV hydration is something that is given not just as treatment, but also as prevention. Some other important cancers to be considering are adult T-cell leukemia and lymphoma, diffuse large B-cell lymphoma, mantle cell lymphoma. Burkitt is a really important one to consider, and lymphoblastic lymphoma. So with that in mind, knowing that IV fluids are really the cornerstone and rasburicase would be an important component of treatment, let's take a look at the other answer choices and figure out why they were wrong. For answer choice E, this patient does have a high leukocyte count, but it's really a result of the acute myeloid leukemia rather than acute infection. And therefore, antibiotics are not really warranted in this situation. For answer choice C, to begin induction chemotherapy, though this patient will ultimately need to undergo chemotherapy to treat her AML, her current lab values indicate her tumor lysis syndrome really needs to be managed prior to initiating that. And in fact, starting chemotherapy at this point would worsen her tumor lysis and worsen the renal injury. Starting chemotherapy might be appropriate if the electrolyte and uric acid levels were closer to normal. As we look at answer choice B, to administer phosphate binders, that might be appropriate if the elevated phosphate was the only lab finding of concern, but it won't correct all of the life-threatening metabolic disturbances that we see here. And then finally, answer choice A. So a bicarbonate drip is not a first-line therapy for tumor lysis syndrome. In the early days, it was speculated that bicarb might help to alkalize the urine in this situation and diminish urate crystal formation, but that's not been substantiated in clinical trials and is definitely the wrong answer for this situation. All right, y'all. Great work. This is, I think, a tough question, although I love to see how many of you got it right. But definitely important to know this for step 2 content material knowledge.
Excellent. Thank you, Kasha. You know, I saw a question, and it was a suggestion that we should do a lab that discusses the differences between First Aid 2020 and First Aid 2021. Unfortunately, our question labs are actually question labs, right? So we do questions on specific topics for the USMLE and do question dissections. Now, as far as the difference between First Aid 2020 and 2021, this is what I always tell students. Your exam is an important one, and it's important to be up to date, right? So that's the first thing. So, you know, after all the investment you made in medical school and in review resources and maybe even board prep, you know, you definitely don't want to sell yourself short and not have the most up-to-date information, especially because there are changes in the exam now, including communications questions, which are covered in the new First Aid. So I highly encourage everybody to purchase their copy of First Aid 2021. It's already out and available. It might be sold out online with certain vendors, but you should be able to get your hands on it. So I hope that addresses the question that was asked. Now with that, I also saw some questions about RX Coach, about pricing, about how we work with students. So the pricing information can be found at rx-coach.com. I think if you take a look, you'll see a couple of things. First and foremost, we are the most experienced company when it comes to medical education and the only tutoring company that actually was involved in medical education prior to getting into tutoring, right? We've assisted hundreds of thousands of students with resources like First Aid and USMLE-Rx. So we have a lot of data, and we use that data to help maximize your study efforts. We are also the only tutoring company that's created our own assessments, right? So we administer our own assessments, and then based on your performance, we come up with a personalized study plan so we can see those strengths and weaknesses. And then we take a data-driven and progress-based approach to ensure that you're studying efficiently. As a matter of fact, our students will tell us a few things. First and foremost, they'll tell us that studying with you helped me get to where I was much quicker. Number two, it took the guesswork out of studying and figuring out what I should be doing and when I should be doing it. Number three, it helped really identify those knowledge gaps and bridge them. And fourth, perhaps equally as important as all the other points, is working on those test taking skills, because when you're in medical school, when you do a USMLE board review course, or you look at review resources, all of those are very content heavy. None of them really address, or very few of them for that matter, address test taking skills and work with you on an individual basis to get there. And because we've authored our own resources, we have access to what we call a faculty portal, which allows us to really see exactly how you're doing and progressing, as opposed to other tutoring companies which haven't created their own resources, which forces you then to share your password so they can go in and check periodically how you're doing. So there are lots of benefits with working with a company such as RX Coach. You have wonderful coaches like Faraz, who you've met in the past, Abraham and Kasha, who you met this evening. And as you can see, our students are extremely happy with the services that we're providing. So, if you're interested in receiving that one-on-one attention to really help you maximize your potential and get that dream residency, please reach out to us at rx-coach.com. Click on that free consultation tab. We do have a promotion running between now and the end of the month, a little bit of a discount here on our packages. So set up that free consultation to discuss the program and how it can benefit you. The consultation, once again, is to discuss the program and how it can benefit you. But if you want some general advice on, how to use our resources or how to plan your studying, or if you even want access to a free study planner, we know that students have those questions, which is exactly why we created firstaidteam.com, which is full of great advice and resources, as well as upcoming events and messages for students at large. So if you're interested, once again, please visit rx-coach.com and schedule that free consultation so that you and I can talk about the program. And once again, firstaidteam.com for those of you who just want some general advice. Okay. So with that, let's go ahead and get into our third question of the evening. Once again, the answer choices are covered up, and we will begin with the lead-in. Which of the following is the most appropriate treatment? So we'll give all of you a few seconds here to let us know how many steps this question will require. And I keep seeing in the question box, a lot of you, when we uncover those answer choices, are jumping right to the answer while we're explaining the important clues to you. I highly encourage you to listen to the presenter, listen to Dr. Bornstein here, and really listen to those test-taking skills so you can have that edge and really get that knowledge from these experts, okay? I'll give you an example. We do Step 2 tutoring, and recently 3 of our Step 2 tutors took Step 2 several months ago at least. And they had a competition to see who would do better, and the lowest score in the group was a 265. Okay, that's an amazing score. It's a really great testament to how qualified our tutors are. So, I encourage you to get the most out of this session by really paying attention to what they're saying. So with that, let's go ahead and read that vignette. A 22-year-old university student comes into the University Medical Center reporting nausea and 3 episodes of vomiting. He has had a history of migraine headaches, medicated with timolol, and has been experiencing frequent headaches over the past several months, for which he has been taking increasing doses of various pain medications that he borrows from others in his dormitory. He has not had abdominal pain or changes in bowel movements, but does have ringing in his ears. His temperature is 102.2 Fahrenheit or 39 degrees Celsius. Blood pressure is 110/60 and pulse is 113. Respiratory rate is 30. Shortly after admission, he becomes disoriented and confused, and then experiences a seizure in the examination room. An arterial blood gas shows pH of 7.4, PCO2 of 20, and PO2 of 112, and a bicarb of 12. Which of the following is the most appropriate treatment? And so with that, I will hand it off to Kasha.
All right, thank you, Sean. So again, let's start out by figuring out how many steps this question requires. So this question is asking which of the following is the most appropriate treatment. And similar to the previous questions that we've seen tonight, this appears to me to be a classic 2-step question. And I even see many of our guests have shared that in the chat as well, that this is likely a 2-step question. And put simply, we have to figure out what is the diagnosis and how do we manage it. So let's take a look at the vignette and think through the pertinent points here. So this question tells us about a 22-year-old with nausea and vomiting in the setting of taking several borrowed medications for migraines, suggesting to me, there's a risk factor here for drug overdose or polypharmacy with synergistic effects. So it looks to me like now we have to determine what the ingestion is and what we want to do about it. Importantly, we see this patient has ringing in his ears. To me, that sounds like tinnitus, hyperthermia, tachycardia, and tachypnea. And something I like to do as I read through these is, as I read the pieces of information or the data points here, I try to think, what is the significance of this? So ringing in the ears, I think that might be tinnitus. You know, the pulse is 113, and you know, it's tachycardia. And so I think about this and I try to figure out why are they telling me this particular piece of information? And that's why we've shaded these terms as we read through them. So next they tell us that he develops disorientation and seizes. And they show us an ABG with this pH of 7.4, the PCO2 of 20, and a bicarb of 12. And so as we keep going through this, I'm just going to ask, what kind of acid-base disturbance are we seeing here? And feel free to share that in the chat. And you can think about it while I keep on reading. So with all that in mind, we can now come back to consider this two-step question lead-in. And let's remind ourselves that we need to figure out what the diagnosis is, and then the next step in management. So let's take a look at the answer choices, starting from the bottom and reading up. Starting with E, naloxone, or D, N-acetylcysteine, C, glucagon, B, flumazenil, or finally A, bicarbonate. Which of these is the most appropriate treatment for what's going on with our patient here? And I'm seeing some of those thoughts, metabolic acidosis, definitely some good thoughts here. So I'll send it back to Sean now.
Excellent. Thank you, Kasha. So I've gone ahead and opened up the poll. We'll wait until about 2/3 of you have responded. Now, some of these questions are tricky, but it's important to keep an organized thought process to know what the test writer is asking. And in our coaching sessions, we'll stop you after every sentence and ask you, what do you think is important? What are you thinking? What's on your list of differentials? What's your thought process like? What are the important clues? What are the clues that are distractors that are trying to take you away from the answer? And so as we do that, we're really able to identify exactly how you apply what you know. And that helps us get intimately involved with your learning process and help you identify any test-taking deficiencies you may have and correct those. Because as you know, the difference between a good score and a great score could be just a few questions. And so you really want to have those sharp test-taking skills. And we're hoping that these question labs are helping you. But if you really want that additional edge, please visit us at rx-coach.com. A few more seconds here. I see about 60% of you have voted. All right, let's take a look and see what you selected.
As Sean likes to say, there's never a penalty for guessing on these questions as well. It's very important.
Yeah, exactly. So if you're unsure on test day or now, certainly, never leave a question blank. So I see here we've got a pretty close call here. 33% of you selected bicarb, 26% of you selected N-acetylcysteine, and 23% of you selected naloxone. So let's see what the correct answer is. And the answer is A, bicarb, and about a third of you got it correct. So great job to those of you who got it correct. But let's make sure you got it right for the right reason. And if you didn't get it right, don't worry. Kasha is going to explain it to you now. Kasha.
All right, nice work, everyone. This is definitely a tougher question. So we're gonna go through and dissect really all of the pertinent pieces of information here so that when you see a question like this on test day, you have what it takes, you have the knowledge and the comprehension to get this kind of question right. So this patient has been taking increasing doses of pain medication to treat headaches. Now it presents with nonspecific abdominal pain and vomiting, accompanied by hyperventilation, or tachypnea, and tinnitus. So when I look at this this ABG, I'm seeing that there's a pH of 7.4, which at first glance might look normal, right? Because that is a normal quote unquote pH, but with totally abnormal PCO2 and bicarbonate values. And So what that tells me is that there's a mixed acid-base disorder suggesting a combined metabolic acidosis with a concomitant respiratory alkalosis. And those together yield a normal pH. Anything but normal going on here. And this patient's presentation, if you take it all together with the tinnitus, the mixed acid-base disorder, that all paints a picture of aspirin toxicity. So you can really get a better sense of his acid-base disturbance using the Winters formula for compensation for metabolic acidosis, where the predicted PCO2 for a bicarb of 12 would be determined by multiplying that bicarb by 1.5, adding 8 plus minus 2. So that would be 12 multiplied by 1.5 plus 8, that'd be about 26 plus minus 2, right? So the patient's measured PCO2 is lower, indicating an added respiratory alkalosis, and that we even see in the vital signs shown with the hyperventilation, right, the high respiratory rate. So aspirin toxicity can occur after an acute overdose or insidiously as a result of elevated doses over time, as in this patient's case. Its manifestation typically involves vague, nonspecific symptoms, such as nausea, abdominal pain, but the more specific alarming symptoms of hyperventilation and tinnitus are what we see in this patient. If unresolved, it can progress to cerebral edema, seizures, and even coma. And importantly, there's this mixed acid-base disturbance of respiratory alkalosis with an anion gap metabolic acidosis because of direct stimulation of the respiratory drive alongside the salicylic acid, which, if you remember from studying for step 1, mud piles, the S in mud piles is your salicylates, of which aspirin is a member of that class of drugs. So additionally, and more importantly, the acidosis is due to aspirin uncoupling oxidative phosphorylation, and that leads to a lactic acidosis. So there's two kinds of lactic or acidoses going on at once. So administration of bicarb alkalinizes the urine, promoting the excretion of acidic drugs such as aspirin and preventing their reabsorption. Highly basic urine deprotonates acids such as salicylates within the renal tubules, and that results in a trapping of those salicylates in the urine and subsequent excretion. All right, so great work for those of y'all who got it right, and I hope that this was useful for everybody else. And let's run through these other answers and discuss why they're incorrect. So answer choice E, that's naloxone, and that's really used for opioid overdose. And that would present with a respiratory acidosis, right? And we see in this patient a marked respiratory alkalosis. So answer choice D is N-acetylcysteine, and that is used to treat acetaminophen toxicity. Acetaminophen toxicity is marked by nausea, vomiting, and malaise, but that can proceed very quickly to fulminant hepatic failure. There's no tinnitus, seizures aren't seen, and that's definitely what we saw in this patient. So basically, N-acetylcysteine functions by increasing glutathione levels by binding to toxic breakdown products of acetaminophen. All right. So answer choice C is glucagon, and that's used to treat beta blocker toxicity. And I've always found the pharmacology of that to be really fascinating. It's sort of a backdoor way of increasing intracellular cyclic AMP because both the glucagon receptor as well as the beta adrenergic receptor is a G-coupled protein receptor. And so you can bind to that with glucagon and increase the intracellular cyclic AMP in cardiac myocytes. Now, very simply, beta blocker toxicity would present with decreased contractility, inhibition of the AV node. You'd see hypotension and bradycardia, maybe cardiogenic shock. And this patient's normotensive, he's tachycardic, making beta blocker toxicity unlikely. And then finally, answer choice B, which is flumazenol. And that's a specific antidote for benzotoxicity that would present with somnolence, slurred speech, maybe some respiratory acidosis. So the bottom line here is salicylates cause a mixed acid-base disturbance and can be treated with bicarb to increase the urinary excretion. Back to you, Sean.
Excellent. Thank you, Kasha. Great job to those of you who got it right. To those of you who didn't, don't worry. We're here to learn so we can get it right on test day, right? You know, if you're one of those students who looks at a question and afterwards is like, I should have gotten it right, or I knew that, or maybe you didn't know it, you know, coaching might be perfect for you because oftentimes students are picking up on those relevant clues, and sometimes those test taking skills or those knowledge gaps can really cause it. And it's oftentimes difficult for students to identify why they're missing questions because, you know, you're not USMLE experts as opposed to our tutors who are. So once again, if you want the help of a USMLE expert, one of our certified RX coaches is happy to work with you. Reach out to us at rx-coach.com. Let's go ahead and do our last question of the evening, and then we will have a raffle. So make sure you stick around because you must be present to win. Once again, the answer choices are covered up, and we will begin with the lead-in. An abnormality of which of the following serum values is most likely responsible for the recent findings in this patient? Let's read that vignette. A 45-year-old woman is evaluated in this hospital for prurial and finger tingling, which started today. She has a history of heavy alcohol use and was admitted to the hospital 3 days ago for withdrawal symptoms, nausea, and severe watery diarrhea. She initially had severe volume depletion and a serum potassium concentration of 2.9, which has improved to 3.1 after 3 days of intravenous saline, potassium chloride, and dextrose. She has not been able to take oral nutrition due to continued nausea. She is afebrile. Her pulse is 68, respirations are 16, and blood pressure is 130/74. Her fluid balance chart indicates normal urine output. Physical examination is significant for facial twitching on percussion of her facial nerve just anterior to the ear, as well as the induction of carpal spasm after the inflation of a blood pressure cuff on her arm. An abnormality of which of the following serum values is most likely responsible for the recent findings in this patient? Kasha.
All right, thank you, Sean. So let's get to work tackling our last question of the evening together. As always, we're going to start this question by trying to figure out how many steps there are. And I see there's already some comments in the chat. So we're going to need to first identify what the condition is that the patient is experiencing. And then an additional serum value that should be abnormal. So this is, I think it's a two-step question. So with that in mind, let's take a look through the vignette and I'll discuss what I thought was the most pertinent information here. So this is a 45-year-old woman with perioral paresthesias in the setting of a history of heavy alcohol use. As I'm reading through this and thinking about it, a recent history of diarrhea and decreased oral intake to the degree that her potassium is quite low. Her vitals are okay. She's got some significant physical exam findings. The facial twitching and percussion of her facial nerve just anterior to the ear, and the induction of carpal spasms after the inflation of a blood pressure cuff. Very interesting. So let's come back to this question now we have some data. An abnormality of which of the following serum values is most likely responsible for the recent findings in this patient? So is it E, sodium, D, potassium, C, phosphate, B, magnesium, or A, glucose? Which of these is abnormal and likely responsible for this patient's findings? Back to you, Sean.
Excellent. Thank you very much. I'm going to go ahead and open up that poll and give you a few seconds here to select your responses. This is our last question of the evening, so let's try to finish strong. And then, of course, we will have the raffle, which Kate is going to conduct. Next week's topic is general pathology, so make sure you join us then. All right, I see the responses coming in. We'll give all of you a few more seconds here. All right, let's take a look and see what you selected. The answers are pretty close here, and we have a tie between magnesium and phosphate. So let's see what the correct answer is. And the correct answer is B, magnesium, and a little over a third of you got it right, but just as many of you selected phosphate. So let's have Kasha explain to us why B is the correct answer. Kasha.
All right, everyone, good work. So let's take a look at this question and put it all together. And let's think about what's going on here. So this patient initially presents with nausea, potentially baseline poor nutritional status. She's now displaying classic signs of hypocalcemia, as several people noted in the chat. She has tingling of the extremities and 2 named exam findings for hypocalcemia. Those of you who are feeling daring, can you put in the chat what those 2 signs are called? Perhaps we can identify some of those. We've got hyperexcitability of her facial nerve, and that's the Chavostic. Excellent, very good, Brittany. And then there's an induced carpal spasm, which is called the Trousseau sign. So an important approach to thinking about this kind of question is by thinking how exam question writers make things more challenging for the test taker. And here, instead of giving you the calcium value, they rely on you recognizing these classic signs of hypocalcemia to determine what might be going on here. So this patient's hypocalcemia is likely secondary to hypomagnesemia, given her 1-week history of diarrhea and chronic alcoholism, and a failure of her hypokalemia to respond to intravenous repletion. Hypokalemia is in part due to the diarrhea that also causes magnesium loss, but also to the effect of hypomagnesemia in increasing tubular potassium secretion. So this is why the patient's potassium did not increase much with intravenous supplementation, and that was a big clue that you may have glossed over as you were reading through this passage. So correction of both hypocalcemia and hypokalemia requires magnesium repletion. All right, so an important clinical point and definitely something that they like to test on the USMLE Step 2. So let's take a look at the other answer choices here, beginning with E. Now, hypo and hypernatremia can cause confusion and seizures, but not the perioral tingling or muscle twitching being described here. Additionally, she received saline throughout her stay, so absent any other disorders, her serum sodium should be normal. They haven't told us anything suggesting otherwise. So answer choice D is potassium, and while she is hypokalemic, low potassium could cause muscle weakness, but not that muscle twitching that we see. Answer choice C is hypophosphatemia, and that is associated with alcoholism and also trauma and sepsis. And although this patient has a history of chronic alcohol use, hypophosphatemia is not likely to be the cause of her symptoms, as it's not associated with facial twitching, carpal twitching, perioral tingling, or finger tingling. Rather, hypophosphatemia is associated acutely with muscle weakness. So for those of you who considered that, you might suspect it instead if you have a patient in the ICU who is very difficult to wean from mechanical ventilation. Remember, phosphate is used to make ATP, which we need to power the respiratory muscles to breathe on our own rather than on a vent. All right, and finally, A, although this patient has risk factors for hypoglycemia, such as history of chronic alcohol use, severe diarrhea, and reduced oral intake, she is receiving IV dextrose, as they painted in the vignette, and she should adequately be able to maintain her blood glucose levels. Furthermore, these symptoms are not consistent with hypoglycemia. It wouldn't cause those Chavostic and Trousseau signs, and her mental state is normal. All right. That's it for me. Great work. Thank you for your attention and your hard work tonight. And looking forward to seeing you next time. Back to you, Sean.
Excellent. Thank you very much, Kasha. Great explanations as always. I hope all of you found that session to be helpful. Here are the question IDs. If you have access to our Step 2 QMax question bank, you can type these into the RX search field and review these questions on your own time. You will notice that some of these answer choices have more than 5 answers. 5 possible answer choices, so we have to truncate them because we can only put 5 in our poll. So feel free to write these down or take a screenshot. I see some comments saying this was awesome. If you have some comments about the question lab tonight, let us know what you thought. What did you learn this evening?